Well, I want to welcome everyone tonight. I hope you've been having an enjoyable time catching up and meeting people you haven't met before, as well as seeing people that you've been meaning to see, but this gave you the opportunity to do so. But this is our fall MSREI meeting, and the real purpose of our meeting is to look through an independent lens at different areas of our field or related ways in which we can care for our patients. And inviting thought leaders from all over the planet has been our tradition for over 2 decades now. It's been wonderful. I think we've all benefited greatly from this. I've learned so much. It's always nice meeting people who may have different perspectives, and ultimately rising tides raise all boats is sort of how I see it. It also affords us to quench our curiosity. This is also a fairly flaky microphone, but we'll see. I will project. In speaking tonight, I wanted to share sort of a story here, which ties into this evening's presentation and program. Way back when I finished my fellowship, who's a fellow here now? There's got to be at least, all right, we have fellow representation this evening. But back in 1990, when I was coming out of my fellowship, I thought I asked every question I can think of interviewing, but I missed one. And I didn't know it till I took the position. This must be a contact-related microphone. And the second day at work in this area, and it was at Henry Ford, I knew the chairman well. He was my mentor from Johns Hopkins, where I trained. And the division head at that time was from Hopkins as well. And we had a same-gender lesbian couple come in to seek treatment with donor sperm insemination. And as we were going to meet with the patient, I was informed by the division head that we don't take care of these type of patients. And I sort of said, what? I was more calm because it was said in a way that I felt very intimidated at the moment. It's my first gainful employment in my life, outside of being a fellow and resident and all summer camp counselor and boating instructor. This was the big times. So I just listened, and this was the way they had done it, and he was the single physician in the division. And I said, I just need to think about this a bit, and sort of stepped back, didn't say much, and went home to my wife, and I said, Mary Jo, I think this may be the shortest job I'm ever going to have. So I went in the next day, having thought it through, and she's a great counselor to me my whole life, adult life, and I just responded that, this is a choice you may have, but the really nice thing about me coming on board is now patients have choice. We increase the choice for care in our community. And he sort of said, fine. And it was, again, rather intimidating. The next step in this story was 2 years later when Alan DeCherney asked us to write on a subtopic of unconventional family building. And I've been working with this gentleman for 2 years now, and he brought it to me. He had trained under Alan, and he looked at me. We had gotten to know each other, and he grinned loudly, or obviously, and he looked at me and I said, yes, this is your comeuppance. Now you're going to have to examine a settled idea. Your father was an OBGYN. This may be tradition in how you've done it. And so we had a psychologist and an attorney, and we really delved into not quite a systematic review, but in writing this publication up, this person introduced his points of view, and publishing was everything, and getting your name on everything. And I had to come to him along with the other 2 folks and say, if you really insist on this being in, and your name goes on this manuscript, and ours do not. Or you can recuse yourself, or sort of bend to the will of society in a new view. And he sort of just didn't recuse himself, but allowed himself not to be included in the discussion. So as much as we tried to persuade this person against his will, he seemed to be of the same opinion still. But I gained confidence that you got to do the right thing. And in learning more about this, it's just very essential that we provide full range of care to everyone in our community. And that was back in '92. So we've come a long way, but it still was to 2016, June 24th, when the Supreme Court finally was catching up with the rest of society a bit. and questioning these kind of ideas and being sensitive to bring forth increased level of awareness is so important. One of the privileges I have, and some of my staff have joined me, is with the medical students at the William Beaumont Oakland University medical students. We do a seminar in ethics and on addressing topics in LGBTQ community. And I think my last explanation here went a little bit further with these first and second year medical students. And some of my patients joined us who have been thought leaders in the community as well, who are activists in this area. And I thought, how can I draw the group in a different kind of way? So I told everyone, I said, I'm going to insist some of you come out. You all know what that means. To identify yourself and how you feel, your sexual orientation, or just feel free to express yourself however you want. But I just said the word come out. And then I said, so I'd like a raise of hands, so you're welcome to stand up to answer this question. But I said, how many of you were raised in a household that was really biased in a way of looking adversely towards same gender or gender fluid individuals that may not be what was considered normal or mainstream? And just not that you feel that way, but how many were you raised in that environment to inculcate in a culture, a point of view? And slowly, about 40 people stood up. And I said, does it feel uncomfortable to have to stand up, even if it's either what you believe, you're welcome to, or that it seems awkward looking back at your childhood and how you were raised? And they all said yes. And I said, so perhaps you can imagine what it might feel when someone is exposed or feels they have to come out. Why should they even have to do this? And that sort of kicked off a really good dialogue for the next hour and a half. To that point, our forum, our SARI forum online, has had quite a number of discussions in this area. And to that point, there was one discussant that just said some really insightful things, or wrote some really insightful things. And I said, who is this person, this Molly Moravek? Then I had to look it up. And I said, And then I looked back later when I finally met with Molly this summer, because I just followed up with her directly. And I realized I had her name in my cell phone since 2012 when she was entering fellowship. And we had had a great discussion just on some general topic, and here I am caught by her again, not connecting directly in the moment, but something unique about Molly that caught my eye again. Some of curiosity, openness, intriguing, in-depth thought, and challenging us to think about things in a more broad and inclusive way. It was just all there in one set of paragraphs. And I said, I have to meet her, and then I realized I'd met her before. And along with that, she's perhaps a New Yorker, but maybe not New York City by her birth, but has been in Michigan since probably about 8th grade, and has sort of been Michigan grown, Michigan roots, went undergrad, University of Michigan, went to medical school, University of Michigan. I'm not sure whether you're turning blue or maize right now, but then OB/GYN residency, University of Michigan. And she went to Chicago, to Northwestern for her fellowship, which of course is the Detroit and Michigan brain drain, Chicago, and then decided to refill the brain by coming back to Michigan, which we're really thrilled for. In particular, she's the medical director of the IVF program at U of M. She's involved very intimately in terms of transgender care and been a particular of interest in hers. Continues to do much research. Northwestern is a great crucible for discovering imaginations and bringing them to life in a lot of ways, working with folks like Teresa Woodruff and along with the clinical investigator masters and her masters in public health. Just amazing. And I said, Molly, you need to enlighten us. We're curious. And I want to introduce you to Molly Moravek. Molly.
Thank you. And I appreciate the invitation to, I might not be able to do this at all, Mike. I appreciate the invitation to speak tonight. And And I feel like I've been set up for failure a little bit with the enlightenment comment, but I will try to do my best. I also agreed with Mike to do a talk on transgender reproductive care, and then he gave me this LGBTQ title. And so I've capitalized the T to make it clear that I'm mostly talking about transgender reproductive care tonight. And so I just want to start with the basics. I'm not sure where everyone in this room is coming from to make sure we're all on the same page when it comes to terminology relating to transgender patients. I want to talk a little bit about what is and isn't known about the effects of gender-affirming hormones on future reproductive capacity. And this all started because Michigan's a little different in that the reproductive endocrinologists take care of the gender patients. We do all the gender-affirming hormone therapy, and I was trained by a very senior colleague of mine. And he told me that we need to be telling our patients that they need to freeze their eggs and sperm before they get gender-affirming hormone therapy. And so I went into the literature to find out exactly what this gender-affirming hormone therapy does to the eggs and sperm, and it turns out there's no data. And so I don't know if you hear my, sorry. I decided to make this my research focus, and I'm actually really trying to change the wave of thinking that maybe, especially in our transgender women, maybe we don't need to be freezing their eggs prior to testosterone. I do want to talk about what we're doing for our ART protocols and procedures in our transmasculine individuals. And then at the end, I'll talk a little bit about tactics for making your clinic more welcoming. And I just wanted to warn you that there's still a lot of questions out there. So this presentation doesn't have all the answers, and it will likely generate more questions. So just to start with the basics, cisgender is a person whose gender identity and assigned sex at birth correspond. In other words, a person who is not transgender. Transgender is a person whose gender identity and assigned sex at birth do not correspond. And in this talk, I use transgender sort of as an umbrella term to pretty much include any gender identity outside of male or female. And then in my personal hormone prescribing experience, I feel like I'm seeing a lot more gender fluid patients. So our patients aren't feeling like they have to be male or female anymore. They feel like some days they're more male, some days they're more female, or maybe they don't feel like either and just identify as non-binary, which is a person who doesn't identify as male or female. And I feel like a lot of us throw around this term gender dysphoria a lot, and it actually does have a role in the DSM-5, but not all of our patients actually experience gender dysphoria, and for some of them it's a little insulting to suggest that they do. And the reason why is because of this number 2, experience clinically significant distress or impairment in an important area of functioning. And a lot of our patients are transgender and are fine with it. They don't necessarily have this clinical distress. And so this is another word that I think we need to be a little careful with. This terminology changes, and I find it's always easiest just to ask a patient how you want them to be referred to. And so when I first started, transgender man was the preferred terminology. Now it's moving more toward transmasculine or assigned female at birth to describe someone whose gender identity is male but was assigned female at birth. Similarly, trans woman, more people now are using trans feminine or assigned male at birth. And probably the biggest point for my patients is that transgender is an adjective. Someone is not a transgender or transgendered any more than someone might be maled or femaled. And it's distinct from sexual orientation. So just because somebody's gender nonconforming doesn't mean that they have a specific sexual orientation. And it's also different from differences of sexual development. And last but not least, when we talk about transition, that can mean a lot of things for a lot of people. For some people, that's just changing their name and the way they dress. For other people, that's hormone therapy, and for some people, that's surgery. And gender-affirming surgery is surgery used to modify one's body. And so sex reassignment surgery is no longer considered okay among our trans patients. And I want to make a little argument for why you need to care. So there's this increasing prevalence. So there was 2 US studies, one out of Michigan, that came out around the same time. And one estimated the prevalence at 0.5%, one estimated at 0.6% of US adults. Either way, it's about 1.4 million. And interestingly enough, this was an increase just over the course of 3 years. And so this is a huge increase in population. And even more importantly, a survey went out to high school students and asked how many of them identified as transgender, and it was 1.8%. And so these are our fertility patients of the future, right? These high school students, we know that teens who have a transgender identity are unlikely to change that identity. And so this 1.8% are the people that we're going to see in about 10 years. And I think part of this increase isn't necessarily that more people are gender nonconforming, but there's also increasing visibility that's making it more acceptable for these patients to come out. In part because of transgender celebrities. I think everyone knows Caitlyn Jenner. There's this increased research focus, myself included. The bathroom bills and the military ban and the CDC banned words, some negative publicity for our transgender patients, but certainly brought them into the conversation. And so as such, the demand for healthcare for these patients is going to continue to increase, but we're not able to provide them high quality care. And that's my argument for why we all need to learn. When we asked our transgender patients, 23% don't seek the medical care they need because they're worried their doctor is going to mistreat them. 33% don't do it due to cost, either because they're underinsured or unemployed. 15% are uninsured. And 55% have to travel more than 10 miles to get their transition-related care. As far as hormone therapy goes, I'm not really looking to make anyone here an expert, but just so you understand what we're talking about and really what any reproductive endocrinologist could probably do. There's 2 sets of guidelines for care. So one is the WPATH standards of care, which involves mental health professionals and basically requires a letter from the mental health provider saying they have a diagnosis of gender dysphoria, any other mental health disorders are controlled, they're of an age of consent. And then there's the informed consent model, which we have transitioned to at Michigan, which basically says they're an adult, you're a doctor, you consent them like you consent for any other procedure, whether it be IVF or birth control pills or a hysterectomy. It's no different when you're consenting a transgender patient for hormones. And so just an overview, in our transmasculine patients, the principal therapy is testosterone that can be given intramuscularly, subcutaneously, or transdermally. And generally, we don't need to get them anything else to get their blood levels of estradiol and testosterone into the male level. And for our trans feminine patients, we generally need estradiol. The most common is oral, but we can do intramuscular or transdermal. And the trans feminine patients tend to need an anti-androgen as well. So many of them are on spironolactone or finasteride to help decrease the effects of testosterone in the target tissues. And again, we're looking for female range blood levels of estradiol and testosterone. And then as was just mentioned, in our peripubertal youth, we have a pediatric clinic at the University of Michigan that's blocking pubertal progression with a GnRH agonist at Tanner stage 2 or 3. And I want to stop on this for a second because I get asked about the youth a lot. And even though I don't personally treat the youth, I see a lot of them once they age out of the pediatric clinic. And there's basically no role for hormone therapy prior to puberty, right? Boys and girls are kind of undifferentiated. They don't have a lot of masculine or feminine characteristics. But we do know that if there's gender dysphoria that persists into adolescence, it's likely to persist into adulthood. And as you might expect, it often worsens with the onset of puberty because that is when someone masculinizes or feminizes. And you see, I trained in the clinic as a fellow, and you see these children who are just devastated over the development of their body into the wrong gender. And currently, there's no agreed upon age for starting hormone therapy. I know some clinics go down to 14 years old. And so in these peripubertal children, ideally we can start this in Tanner stage 2 to 3 before they've transitioned too much into the wrong gender. And it basically not only prevents the development of their unwanted secondary sex characteristics, but it also gives the child and the family some time to think through this and decide if they really want to take the next step of doing gender-affirming hormones. We also see a lot of progestins for menstrual suppression. In our post-pubertal trans feminine youth, getting their period is often one of the most distressing things these kids face. And so even if they've missed the cutoff for doing the GnRH analogs, at least giving them a progestin to stop their menses is really helpful for them. And our goals are basically to induce the desired secondary sex characteristics. So in our transmasculine patients, we see voice deepening, we see the growth of terminal hair, they get more muscular. In women, we see breast growth, also body composition changes. So I always counsel my patients that women tend to carry fat in their butt, hips, and thighs. Men tend to carry fat in their guts. And fortunate or unfortunate, you will see those transitions in fat distribution as you transition. We also see some mild regression of their already established characteristics, and so in the transmasculine people, they do get some reduction in breast size, they stop getting periods. And in the transfeminine, it's very hard to get rid of the facial hair, but their terminal hair does decrease in thickness and darkness. They lose muscle mass, the gonads become smaller, and they lose spontaneous erections, which again is very distressing for a lot of our transfeminine patients. This isn't about hormones, but because we're talking about fertility, I did want to talk about the interest in surgery. So you can see at the top the hysterectomy, 14% have had it, 57% want it someday, and so that's a sterilizing procedure when the ovaries are removed. Similarly, orchiectomy is a sterilizing procedure for transfeminine patients, and over 50% have either had it or want it someday. And so if these patients are interested in fertility, it's important to talk to them about their options before they go through these surgeries. So what do we know? And the answer is not much. The effect of long-term gender-affirming therapy is pretty much unknown. There's very few human studies. They're all observational in nature. Most of them assess short-term therapy, so people who've only been on testosterone for a few years, and they have mixed results about how detrimental it is. Even less, and I would actually say nothing, is known about the transgender adolescents who started a GnRH agonist in puberty, so never went through final maturation of their eggs or sperm, and then went directly into the hormone therapy of the opposite gender. And as I already mentioned, the surgeries remove the gonads and are obviously therefore sterilizing. And the reason why we don't know that much is because no one's researching this. I just updated this a week and a half ago, and my other interest is oncofertility and fertility preservation. If you type cancer and fertility into PubMed, you get almost 13,000 hits of research studies that have been on this topic. If you type transgender and fertility into PubMed, you get 124. And so it's just a really understudied topic, and hopefully with time, we'll know more, because I have to say the majority of the hits on transgender and fertility have been published in the last 5 years. Nonetheless, our major societies come out and say that we need to be discussing reproductive options with these patients before they start medical treatment. And so ASRM, our main society, Endocrine Society, which a lot of us subscribe to as well, have come out and basically echoed the sentiments of the Transgender Society and say we have to be offering fertility preservation to these patients before they transition. Although I compliment ASRM for also noting that we need to let them know that we have no data with which to make this recommendation. What we do know is that about 50% of transgender people, when surveyed, express a desire to have children. When they went back and asked transgender men, would you have frozen your eggs if it was available to you, about 40% who did not get that opportunity say they would have. When we do mental health studies, transmasculine individuals with children do better on mental health scales, and transgender women with children have a lower suicide risk than their childless counterparts. And not that I should have to say this, but there's absolutely no evidence that having a transgender parent results in any adverse outcomes for their children as far as psychosocial functioning or even gender identity goes. When we ask transgender youth, they're a hard population, similar to our youth with cancer, right? They don't really know what they want out of life. And so when we ask them, do you want genetic children someday? About a quarter to a third say they do. About a quarter don't know, which isn't really surprising. And when they looked at transgender youth who underwent fertility preservation, it was emotionally and physically demanding. And this was even in the patients who said, I really wanted to do this. I thought about it for a long time, and I'm glad I did it, but it was still distressing. And so I think these are things we need to keep in mind when these patients come into our clinic, and I'll talk a little bit more about this at the end. And despite 50% of adults, more than 50% of adults saying they want biologic children, despite a quarter to a third of youth saying they want biologic children, there's extremely low utilization of fertility preservation services in the transgender individuals who are undergoing a medical or surgical transition. The only studies we have so far are published in youth, but only about 2 to 5% pursue fertility preservation despite counseling. And these are from programs that are designed to talk about fertility to these youth. And in both studies, every single patient that pursued fertility preservation was assigned male at birth, so did sperm freezing. None of them froze their eggs. So at Michigan, we asked our patients, and I'll admit this is a little bit of a biased sample because the reproductive endocrinologists do the hormone therapy, so of course we're talking to our patients about fertility. But you can see in red is the transgender women, in blue is the transgender men, and so the majority of them felt they'd been counseled adequately about the potential fertility effects and their options. Very few, and again, only assigned male at birth, had actually pursued fertility preservation. We had a Likert scale where we asked, how important is it to you to have future children, from not at all important, somewhat important, a little important, a lot important, extremely important. And as you can see here, 40% of our transgender men said it was extremely important to them, yet 0% had pursued fertility preservation. And then when we asked, well, maybe the reason why they're not doing that is because it's not that important to them to have genetically related children, 11% of those said it actually is extremely important to me to have genetically related children. When we asked why they hadn't done it, not surprisingly, cost was a top barrier to fertility care for these patients, but also the lack of desire for future genetic children, the fear about having to take additional hormones. And so our transgender men didn't realize that they wouldn't have to take different hormones to freeze sperm. The need to stop hormones, a lot of these patients were already transitioning and they didn't want to stop their estrogen, or the ones who weren't transitioning didn't want to delay the initiation of estrogen. Our transgender women had very similar barriers, except for the other one that popped up in this population was the possibility of regret. And so when you have a transgender person in front of you, you need to remember that their options all depend on who their partner is and what they and their partner are willing to do, right? And so for my transmasculine individuals, I always just kind of bring it down to, does your partner have sperm or not? And for these patients, a lot of times using words that tend to be very gender affiliated, like sperm or pregnancy, doesn't go as well. And so we just talk about gametes and organs. What organs does your patient have? What gametes do they have? What organs do you have? Do you have a uterus? If so, are you willing to carry a pregnancy in there? For our transgender women, does your partner have ovaries and uterus? Are you willing to have sex to have a baby? Or do you need us to do an insemination? And so I think it's just best to take it really broad, no assumptions, just get the organ inventory, get the gamete inventory, get what anybody's willing to do or not willing to do, and then figure out their options from there. So let's start with transgender women, because I am a reproductive endocrinologist, and so I don't do as much with male fertility, but I didn't want to leave them out. And so this was one of my patients who I ended up referring out to our urologist, but as a 25-year-old trans woman who wanted gender-affirming surgery. She'd been on estrogen therapy for 2 years. She had to stop estrogen for 4 weeks prior to her surgery, so she said, great, can I freeze sperm before my surgery, but was unable to ejaculate. And so I bring up this case because I want to remind people, and I know it seems obvious, but this gets missed by my colleagues on the medical side a lot, that these patients are just like any other patient. They're just like your oncofertility patients, right? If they can't ejaculate, call urology and ask them to do a testicular aspiration. You should treat them just like you would treat any other person who needed to freeze sperm who wasn't able to. So what do we know about needing to freeze sperm before estrogen or after? Some histologic studies tell us that there are some differences in trans women who've been exposed to estradiol. So they have smaller seminiferous tubules, they have an abnormal appearance of their Sertoli and Leydig cells, we see this fatty degeneration of the connective tissue in the testes, and they do have a maturation arrest of sperm production. And this is regardless of anti-androgen use, which is what most of us thought. If they're using an anti-androgen, that's why they're not making sperm. But even the ones who were just on estrogen showed this. But the incidence of this differed vastly among studies, and so it's still very hard to counsel these patients. And so then there was a more recent couple of studies that looked at the semen analysis. And these were great studies because they looked at them both on estradiol and then after they stopped estradiol, because that's the real question, right? If estradiol does something, is it reversible? And so the patients on estradiol definitely had worse parameters, but sperm was still present. And they had extremely variable histology. And it was interesting, so if the estradiol was high and the FSH and LH was low, that didn't necessarily predict their sperm quality. And so the bottom line that we're telling patients is fertility preservation is possible even after you start estrogen. Maybe you couldn't afford it before you started estrogen. Maybe you weren't interested in it. Maybe you didn't have a partner yet and didn't know this was important to you. It's still possible. We should still try, but we may not get the same level of results. The really strange thing is that I have 2 listed here. There's actually been 3 studies now that have looked at semen analyses in transgender women who have never taken estrogen or any anti-androgens, and they also have an increased incidence of abnormal semen parameters in count, motility, and morphology. And this was even after they controlled for behavioral things like tucking, or maybe some of our trans feminine patients try to increase their yams or their soy. Even when they controlled for all these behavioral differences, they still found worsened semen parameters. And so this is a big question for us is how much of that semen parameter difference is due to the estradiol and how much was already pre-existing before they even started. To move to transgender men, I have a few cases. These are all based off real cases. So a 24-year-old who wants to start testosterone, nothing concerning, engaged to be married to a cisgender man, and it's really important to them to have genetically related children. He doesn't want to carry. They've got a friend who's willing to carry for them, but they don't want to do this for 7 to 8 years. He's 24. And so I talk to them about IVF. I talk about how much it is, and both their faces turn white, and they say, we've been saving all this money for our wedding. Is this so important? Like, is my fertility so fragile? Do I need to do this now and miss the wedding of my dreams? Or can I wait, have my wedding, and in 7 to 8 years, save money up again and do this? So what do I tell them? Another patient was a 32-year-old who presented to clinic with his cisgender female partner. He'd been on testosterone therapy for 15 years, has been amenorrheic since starting testosterone, and they both want to participate. So they want to create embryos with his eggs and donor sperm and then have his partner carry the pregnancy, but they're worried about how much it costs, whether or not it's really going to work. They worry how he's going to feel while he's off of testosterone and during stimulation. Is this going to worsen his gender dysphoria? He had a history of suicidal ideation. Is he going to become suicidal again off of testosterone? And is anything going to happen to his offspring? Does that exposure to testosterone change anything about his eggs that we will then see downstream in his children? How do I counsel them? How do you counsel them? And if they decide to move forward, what protocol are you going to use? Are there any adjuvant medications we could use to make it easier for this patient? And last but not least, my most challenging patients, a 14-year-old transgender boy who comes with his parents to discuss fertility preservation. He's been on Provera for menstrual suppression and is planning to start T at age 15. And he thinks he might want biological children in the future, and his parents say, look, we want to give him the best shot. I kick the parents out of the room. I say, look, do you get this? Do you really want this? And he says, yeah, I've done a ton of research on this. I understand the process. I don't think it's going to be pleasant, but I will do it if that's what you recommend I need to do to have my biological children. So what do you recommend? Does he have to do this? And what if he'd been on GnRH agonists since Tanner stage 2 to prevent his pubertal progression, so his eggs had never matured? Can you stimulate that patient? So we know a little bit. There's a lot in the popular press about transgender men who've chosen to carry pregnancies for whatever reason. And so we certainly know it's possible. We just don't know how likely it is or how efficient it is because we don't know the denominator of men who've tried. There was a great study that came out on transgender men who'd had a live birth, and about 84% of the subjects who'd been on T before pregnancy did use their own eggs. So again, we know it's possible. But this study selected for all people who'd have a live birth. So this doesn't count the people who tried and didn't get pregnant. It doesn't count the people who got pregnant and miscarried or had an early loss. And so again, we don't know the denominator. We don't know how efficient trying to get pregnant after testosterone is. I will note that about a third conceived while on testosterone accidentally. And so my other point, because this is a talk about fertility that I haven't really made in this, is that testosterone also is not a definitive contraceptive. And so we give patients these mixed messages where we say, don't use it as a contraceptive, but you better freeze your eggs if you want biological children. The same group actually recently published a second study in 197 transgender men. And there were 60 pregnancies among 32 respondents, but only 10 had been on testosterone previously. But it's unclear whether the majority of pregnancies were in the men who'd never taken testosterone because they're more likely to get pregnant, or if it's because they knew they wanted to get pregnant, so delayed starting testosterone until they built their family. And sadly to me, just over half said their healthcare providers never asked about their fertility desires before they started their hormone therapy. So a lot of people ask me, like, why don't you just look at AMH? That'd be really easy, just draw it when you draw their blood. And so there actually is 2 studies to look at the effect of testosterone on AMH. Unfortunately, one showed a decrease in AMH, one showed no change, and neither was very clean. In the Canon study, they also had them on GnRH agonists and aromatase inhibitors, and in the TAC study, they also had them on progestin. So neither of these really isolate for us the effect of testosterone on AMH. Similarly, since 1986, people have been looking at the ovaries of transgender men at the time of their surgery. Most show a polycystic ovary appearance. The 3 I highlighted said there's actually no difference at all. They're fine. One showed some men were affected, some men weren't. We do know that transgender men also have an increased incidence of polycystic ovary syndrome at baseline. And so it's hard to know, again, is this PCOS appearance because they already had it, or is it because the testosterone did it? And you'll also notice in the T exposure here, a lot of these patients were only on testosterone for a couple years. And so this doesn't answer the question for our patients who've been on it for 20, 30, 40 years. There's some case series on fertility preservation, but unfortunately, all but the last one were fertility preservation prior to starting hormones. So again, it can be successful, but we don't know what the testosterone does. I actually wish I had highlighted this last study a little bit better than on this slide. It really was sort of a groundbreaking paper. It was a case report in the New England Journal out of Pittsburgh. And they did freeze eggs in a transgender adolescent who had been on GnRH agonists since Tanner stage 2. And they kept him on GnRH agonists during stimulation. The problem is this is becoming a cautionary tale. It required a very long stimulation, kind of similar to someone you might see with hypothalamic amenorrhea or Kallman syndrome. It required higher than expected doses, and in the end, they only froze 4 eggs. I personally know of other people in California who've done this and who have gotten 20 to 25 eggs. And so while I think this was really groundbreaking for someone to come out and say, yeah, we can do this, a lot of people are using this study to say we shouldn't do this because we only got 4 eggs, and there are other successes out there that have not yet been published. When we ask how fertility preservation goes, right, because that's one of the questions our patients often have is how am I going to feel during this? There was one qualitative study of fertility preservation experiences in trans men, about half of whom had started testosterone prior. And not surprisingly, the majority found resumption of menses, which is what happens when they stop testosterone, to be distressing. They found the increased estradiol levels distressing, and it's hard to separate out what's psychological versus true physical changes because they noted things like voice heightening, which is physiologically improbable, but nonetheless, it had this effect on them that they felt it was sort of changing them back to their feminine characteristics, and they found it very distressing. Unfortunately, the study didn't ask them if they were happy they did it or if they regretted it, and it also didn't ask about any medical outcomes. So it still isn't helping us with this question of testosterone and future fertility. So the first study of ART outcomes came out earlier this year out of UCSF, and they compared cisgender women to transgender men, and then they looked at transgender men who'd never been on testosterone versus those who did have a testosterone therapy history. And as you can see, there was no difference in the eggs retrieved or the number of mature eggs between the cisgender women and the transgender men. There was an increase in eggs retrieved there was a difference in eggs retrieved from the transgender men who had never had testosterone. They had more than the men who had been exposed to testosterone. There was no difference in mature eggs. The problem is this study had 13 transgender men, and so it's very hard to know if they would have seen more differences if their study had been bigger. And the quality's not known, right? These are frozen eggs. We don't know if they're gonna fertilize. We don't know if they're gonna turn into babies. We just know they're frozen eggs. And so this study just came out this month looking at cisgender women compared to transgender men. This is out of Boston IVF. And they found more eggs retrieved in the transgender men, interestingly, which maybe goes toward the philosophy of using something like testosterone in women with diminished ovarian reserve. Maybe it's actually activating something. But they did notice that they needed significantly higher gonadotropin doses than their cisgender counterparts. They then looked at cisgender women age-matched with transgender men with a testosterone history, and those differences went away. We no longer saw an increased number of eggs retrieved, but we did still see significantly more gonadotropins needed. But again, in this study, the transgender men with a testosterone history was only 16. They did look, which the other study did not, to make sure there was no differences in age or AMH or BMI to explain these differences, and it wasn't. And in both these studies, testosterone was stopped before stimulation. And so when I see one of these patients, I think about a few things. One is, do we need to stop the testosterone, right? We know that stopping the testosterone is going to increase their dysphoria, and there's some clinics that are stopping it for 3 months to allow folliculogenesis to complete without any testosterone exposure. There's others that think testosterone could be stopped just before, maybe they just need 1 menses, maybe they don't need menses. And my question is, can we just maintain testosterone during stimulation? I have a colleague in Canada who never even thought twice about this. She just always leaves them on testosterone during stimulation, and they've got live babies, they've got euploid embryos, and so we are actually shifting our thinking a little bit at Michigan to counsel our patients that they at least have the option of staying on testosterone, even though we don't know the outcome of staying on testosterone any more than we know the outcome of not staying on testosterone, you know, but we do know it'll increase their mental distress if they go off. In our patients who are stimulated, we tend to use aromatase inhibitors, just like you would in a breast cancer patient, to keep their hormones level low, to try to decrease that dysphoria from the increased estrogen levels. And you have to remember that vaginal exams can be very distressing for patients who are not comfortable with their anatomy, and also long-term testosterone treatment leads to vaginal atrophy and dryness. And so certainly a lot of gel if you're going to do transvaginal monitoring, but in our patients we have amazing ultrasonographers in our clinic, and so we do mostly transabdominal monitoring for these patients, and in those that we can't, we try to use pediatric probes. And then remember that this patient may not want to carry this pregnancy, and so due to my inexperience, I got a little burned with the first patient I ever brought through by not doing FDA lab testing, but most of them will eventually use a gestational carrier. As far as ovarian tissue cryopreservation goes, it's certainly supposedly still called experimental. I hear that that label is going to be lifted in the coming months. It can be performed at the time of gender-affirming surgery, so that seems to make sense, but both the provider and the patient have to be okay with that. There's really no data on OTC in transgender patients. I don't know if everyone in the room knows what ovarian tissue cryopreservation. I just put a few slides in here in case you don't. Basically, you take out the ovary at the time of surgery, you remove the cortex of the ovary, you cut it into small pieces, which you can do because all the eggs live in the outside of the ovary. That's what those arrows are indicating, and then it can be frozen. The problem is for transgender patients is that currently our only option is to put that tissue back in the patient. So if they don't want to carry a pregnancy, if they don't want those hormones from that ovary back, this isn't going to work for them. And also, we don't have a lot of data about ovarian tissue that's retrieved from patients who have not gone through puberty yet. So this wouldn't necessarily be a great option for someone who's going to start GnRH agonist therapy. We are moving the field of OTC forward, and so there's people looking at maybe can we just mature these follicles in the lab and do in vitro fertilization. And then I know one of our biomedical engineers at Michigan and people at Northwestern are working a lot on engineered environments for follicular tissue transplantation into others. So all these questions remain. There's this gap between the number of transgender individuals who want children and those who actually have them, and we don't totally know why. We don't have a ton of data on long-term gender-affirming hormone therapy, and there's no data on the puberty blockers. And so to address this, my group at Michigan created this mouse model, and basically we had some key characteristics that we wanted men in mouse to be the same in. We wanted them not to cycle, we wanted our mice to have testosterone in the male range, we wanted their LH to be decreased by the testosterone, and we wanted to see this polycystic ovarian morphology, and we did achieve all of that. I'm actually going to skip that slide. We see clitoromegaly, just like we see in our transgender men. And we see this preservation of early follicles. And I don't mean to get really scientific in this, but I did want to bring this up because I think it's an important point. In our testosterone-exposed mice and in our control mice, the primordial, primary, secondary, and actually early antral follicles are the exact same count. It's really only the corpora lutea, so they're not ovulating, and they do have some cystic appearing antral follicles, but all their early follicles are completely preserved. So what that says to me is that, yeah, we're stopping them from ovulating, but we're not actually affecting their resting pool of follicles. So therefore, I'd expect them to have the same ovarian reserve as someone who had not been exposed to testosterone. The other thing we found is that our mice start cycling again after we stop testosterone. It took a little longer than we had hoped, and now our mice are old, but they did start cycling again. We looked at their ovaries, and we were really concerned because their ovaries look different. You can see on the bottom right, it looks kind of like foamy and pink compared to the control on the left, and the reason why I bring this up is because all we have right now is looking at ovaries at the time of surgery, and so it's really easy to say this ovary looks different. There must be a problem. But our testosterone mice actually have litters at the exact same rate as our mice who've never been exposed to testosterone. So even though their ovaries look different, even though it doesn't look like they're ovulating quite as well, they have the same number of babies, and those are our first little testosterone babies that we're all very attached to. So last but not least, what can all of you do? So ACOG basically came out and said that OB-GYNs are uniquely poised to take care of these patients. They should be taking care of these patients. And when these patients come in because they don't access healthcare all that often, we need to talk to them about preventative care as well. And so it seems a little backward for a fertility doctor, but we probably need to bring up contraception as well if they don't desire to carry a pregnancy. We need to bring up STD screening and those sorts of things when we see these patients as well. The problem is we're not trained to do this. And so when we ask our residency program directors, less than half even have ever seen a transgender patient, and only a third of those have the residents participate, and less than 10% see more than 10 transgender patients per year. When you ask practicing OB-GYNs, only about a third say they feel comfortable caring for transgender women, and 30% feel comfortable caring for transgender men. Fortunately, a majority are willing to perform PAPs on transgender men or breast exams on transgender women, but 60% don't know the breast cancer screening guidelines for transgender women. It's the same, right? These patients are the same. If you have breasts, screen the breasts. And so fortunately, one of our colleagues, she was a, Robert Wood Johnson Fellow at Michigan, and she actually isn't an REI, but we love her so much. We hired her into the REI division, Daphne Strunza, partnered with ACOG and CREOG and made these modules that any ACOG member can access on transgender healthcare. There's 5 modules, and it really runs the gamut from preventative care all the way down to legal and how to bill for these procedures. If any of you are really interested, I'd be happy to share any of these websites. There's a ton of really good information online. My personal favorite is the Endocrine Society guideline because it really goes through the evidence behind everything step by step of how to care for these patients. And so because Mike included the LGBTQ in my title, I'm just going to spend a few minutes on creating an inclusive space. And I actually want to pause here for a second because Dr. Strunza, who I mentioned a second ago, is outwardly, so I'm not outing her, but is outwardly a sexual and gender minority. And at our faculty meeting 2 weeks ago or maybe it was a week ago, before I made these slides, she brought up something that resonated with me. You know, she said, I know you're all inclusive, and I know you guys treat sexual minorities and gender minorities just like you would treat any other patient, but you don't have any signage to say that. And your silence speaks just as loudly as if you had something posted that said you wouldn't treat these patients. And she said, so for a patient from the outside, the fact that we don't have signage in our clinic speaks loudly to these patients that we are not a welcoming clinic, which was hard for us to hear as providers who are very engaged with the community. And so just even since that time, we've been making strides toward this. And I did want to bring up that lesbian, gay, and bisexual people want to have kids at the same rate as anybody else. And these numbers are actually increasing, probably because of access. However, LGBT families or the LGBT community is more likely to accept non-traditional family structures. And so I think it's always good to ask, you know, who are this child's parents going to be? Who are the third-party reproduction people going to be? We find that a lot of our lesbian patients would really rather use a known sperm donor than an anonymous sperm donor. And a lot of times they have these close friends who are donating sperm and helping raise the children as well by choice. And so we really have tried to decrease our, I guess, our judgmental language and our gender-specific language and just say, you know, do you have a partner? Do you have a spouse? Are you currently in a relationship? Tell me about it. We've found the hard way that just because a man has sex with men, he doesn't necessarily consider himself gay. And a lot of our female patients refer to their female partner as their wife, even if they're not married, and it's really important to them that you recognize their wife as that as well. And then I think it's also easy to forget, but important to remember, that these patients have a lot of issues before they even walk through your door, right? They had to deal with the process of coming out as LGBT. Some of them are rejected by their family. Some of them are rejected by their workplace. Partnering wasn't always easy for these patients. It's not easy to become parents. They can't just have sex. They have faced discrimination in their housing, in their work, in their children's education. And so it's really important that we remember this when we're encountering these patients, that they may not come from the same place as some of our other patients do. And so ACOG, that same committee opinion, basically came out and said, or I'm sorry, this is a different committee opinion about caring for lesbian and bisexual patients, said you need to train the receptionists, the staff, the nursing. It's not just about the doctors being woke, as the current terminology is. You need to state and have written non-discrimination policies, modify your forms, questionnaires, and research protocols to be inclusive. Be aware of unique risk factors in these populations. Use inclusive history taking and language, unisex bathrooms, and make sure the patients know that they have confidential treatment. And so this is, I can send anyone the PDF of this. It was this huge national movement, actually urged by the Joint Commission. And so all of these slides come out of this Joint Commission statement.
How to provide for the LGBT community. And obviously this doesn't all apply to fertility providers, and so I just pulled a few of them that do. And so one is to prominently post your patient non-discrimination policy, and I'll show an example of that in a second. Make sure your waiting rooms, as Dr. Strunza, my colleague, was mentioning, make sure your waiting rooms don't just have, aren't just free of anti-LGBT material, but make sure they actually have things that tell people we are an LGBT-friendly clinic. Make sure your forms don't make people feel isolated. And then a lot of places are changing their single-stall restrooms to gender-neutral restrooms. And so the recommended non-discrimination statement's up on the top right. Basically says this office appreciates the diversity of human beings and does not discriminate based on race, age, religion, ability, marital status, sexual orientation, sex, or gender identity. This is an example of a lot of the all-gender or no-gender restrooms, and then an example of a marker to the LGBT
community that you are a welcoming and inclusive clinic. And then Dr. Strunza, you can tell she's like one of my favorite people, also wrote this really nice piece in AJOG reminding us that when we say things like women's health, we are isolating our transmasculine patients, and that we really need to sort of rethink all these words that we use in gynecology, not for all our patients, but just to be sensitive to the fact that a patient who doesn't identify as a woman might be really turned off by the fact that we say women's health. There's several publications, I just pulled one of them, and this is actually, I'm embarrassingly part of this Facebook group of OB-GYN moms, and papers like this have been creating outrage, that anyone would suggest that we should use words that are different from the anatomy that we have learned. But at the end of the day, they're not asking you to use different words for all your patients. They're just telling you some words that might be more comfortable for a transmasculine patient. And so things like external pelvic area or internal organs, internal parts, instead of saying uterus or ovaries, chest instead of breasts, cancer screening instead of pap smear, and those sorts of things to make our patients more comfortable. As far as data collection and use, I'm going to talk a little bit about how Michigan does this, but it's important that we can collect this data at registration so that these patients don't feel continuously misgendered at every step in their hospital stay or their clinic visit, to make sure they know that their disclosure of this information is voluntary, to train all your staff about how to ask these questions sensitively, and obviously ensure that privacy protections are in place. And so this is actually the current recommended two-step question for asking gender identity. First, what is your gender identity? And you can see the options there. And then what sex were you assigned at birth on your original birth certificate? And this is coming from the Human Rights Campaign, and this is how they are suggesting that we change our questionnaires to assess for gender identity, both in clinic intake forms and in research surveys. And so at Michigan, we've actually changed our EMR so that you can see the preferred name of a patient and what pronoun they prefer. And so the patients can actually fill out this form in advance. They can say how they identify. They can say their sex at birth. There is this little warning there. Your pronouns will be seen by all clinicians. So if you're not out to all your clinicians, you might not want to do this, and you can say decline to answer. But if you are a transmasculine individual and you use he, him, his pronouns, this will now show up in your chart. It actually pulls automatically into our notes the proper pronouns, the proper name pulls into our notes. On their ID bands, the proper name goes on it. On the stickers when they check in to an outpatient clinic, the correct name goes on it. And this has really helped our MAs and front desk staff not misgender our patients. We also have a website that lets our patients know that we are happy to provide transgender services. And then actually, because patients are often confused about who does what, they can fill out this form about what services they desire, and then the gender services program will get them to the proper physician. And fertility preservation is on here, and that's how a lot of those patients get to us. And then last but not least, one of our residents came up with staff education. And so this is actually targeted at our clerks, medical assistants, security, and janitorial staff, so that, again, no patient is misgendered or meant to feel unwelcome when they're in the hospital, because just because your doctor or your nurse refers to you the right way, if the person who brings you your dinner refers to you the wrong way, that's still going to make you uncomfortable. And if I leave you with nothing else, it's assume not. So these patients come into our clinics in all sorts of shapes and forms, and they're all willing to do different things. And so for some of our patients, even if they are transgender or bisexual or pansexual, having sex with their partner is a fully acceptable way for them to reproduce. For other patients, it is not acceptable at all. And so both when it's coming to contraception and fertility, I make sure not to make any assumptions when I'm encountering these patients. And I think that's all I've got. Thank you.